Hello everyone, this is Brainless Medico and I am Dr. Manoj, and today we are going to learn one more important topic under hematology section, that is megaloblastic anemia. Important topic from secondary people will be learning. I think nothing more should be explained. I'll stick to the topic actually what is necessary in medicine. And even pathology people who are seeing, you can watch it. I almost covered what you can write in second year also. So definition goes like this: megaloblastic anemia is a macrocytic anemia caused by defective DNA synthesis, which results in ineffective erythropoiesis, and characteristic is like megaloblastic changes in bone marrow. So you have to remember megaloblastic changes will be seen in bone marrow. So then etiology, we have vitamin B12 deficiency and folate deficiency. Folate is which vitamin? Any idea? Drop me in the comment section, okay? Poor dietary intake in both. We have poor dietary intake, then malabsorption, pernicious anemia, post-gastrectomy, ileal disease or resection. Same, even here, poor nutrition, alcoholism, malabsorption, increased requirement. In physiologically, pregnancy will be like they need more, so we'll be supplementing folic acid, right? How much we are supplementing? Use the comment section. I'll check. Then in hemolysis, drugs methotrexate, phenytoin. Pathophysiology, it's too complicated. Let's make it simple. And I know, like you people even want normal absorption of this vitamin B12 and folate. I'll be making separate video for that absorption part because even iron deficiency anemia requires mucosal block theory and all. I'll be making separate videos for every metabolism and absorption thing. No need to worry. I'll be uploading soon. Then pathophysiology, deficiency of vitamin B12 or folate leads to impaired DNA synthesis, so DNA will be gone. Then defective thymidine formation leads to nuclear cytoplasm asynchrony in erythroid precursors, leads to ineffective erythropoiesis. At last it leads to ineffective erythropoiesis, increases intramedullary destruction of red cell precursors, bone marrow becomes hypercellular with megaloblastic changes, leads to macrocytic anemia. I think it was a bit complicated. Nothing, just remember deficiency of B12 and folate leads to impaired DNA synthesis. Which part of what you say nucleotide will be affected? Thymidine. Okay, thymidine formation will be gone, which leads to ineffective erythropoiesis. And at last what happens? Intramedullary destruction of red cells precursors will take place, which leads to hypercellular with the megaloblastic changes in bone marrow, leads to macrocytic anemia. If you did not understand, you can just rewatch it. I explained it twice so that it will be 4 times, you'll be clear. And I think same it has been printed in the image. If you want, you can just pause the video, read it. Yeah, it also in like after reading completely, we will try to solve it. Then coming to clinical features, as I said, fatigue, pallor, dyspnea. Then gastrointestinal features, glossitis, weight loss, diarrhea, and even one more you can remember, discoloration at knuckles. Discoloration of knuckles. There will be blackish discoloration of knuckles, okay? Then neurological features only in B12 deficiency, peripheral neuropathy, discoloration at knuckles. Discoloration of knuckles. There will be blackish discoloration of knuckles, okay? Then neurological features only in B12 deficiency, peripheral neuropathy, subacute combined degeneration of spinal cord, loss of vibration and position sense, cognitive changes. Investigations: complete blood count, hemoglobin decreased, MCV increased. If you have not watched my iron profile video or something related to that, you have to go and watch. Please, I'm requesting, because you won't remember anything if you just see increase, decrease, increase, decrease. Nothing you are going to fetch, okay? Just go and watch. It's of around 10 minutes video and you will be clear with the iron profile stuff. So please go and watch. Then pancytopenia may be present. Peripheral blood smear, macroocytes. Then hypersegmented neutrophils will be seen. Biochemical test: serum vitamin B12 decreased, serum folate decreased, LDH increased, indirect bilirubin increased. Yeah, Schilling's test and all we need to explain. I'll try to make that in detail 3-marker video separately. to make it like proper answer how you can write. So I thought I'll skip here because it will be again twice. So I'll make separate video of links. If you watch this, you can just go and watch if whenever I upload. So don't forget to hit on that subscribe button and you'll be getting the notification. Bone marrow examination, hypercellular marrow, then megaloblastic erythropoiesis. When you see the what you say PVS, you're going to see teardrop RBCs, hypersegmented neutrophils, macrovolucytes, as I said. Then in biopsy, you're going to see giant band form and megaloblast. Then coming to DDs, important. If you want, you can just make, so you can watch wherever it is available, or I'll try to make a separate video about this. B12 deficiency and folate deficiency, there is nothing much difference, but a small slight changes because absorption site is different for vitamin B12 and folic acid. I'll try to incorporate this part in that what I said related to metabolism part. I'll try to incorporate if possible. Then megaloblastic anemia versus non-megaloblastic anemia. There is nothing much difference. Only causes will be different. So megaloblastic causes will be, as I said, vitamin B12 and folic acid. And non-megaloblastic, I'll try to make a video if possible. Then management, you have to give vitamin B12 replacement in the vitamin B12 deficiency. Obviously, there is something deficiency. You have to give the particular vitamin. And in folic acid supplementation, in folic acid deficiency, treat the underlying cause. And remember, never ever give only folic acid to patient because it may correct anemia, but it will leads to neuropathy. So always in folic acid deficiency, you have to give both. But vitamin B12, you can give only vitamin B12. Okay, just don't get confused. Okay, examiner try to confuse you in the Viva. Okay, then complications, irreversible neurological damage in vitamin B12 deficiency. So you have to diagnose it quickly and you have to treat the patient because it's irreversible. And heart failure in severe anemia, obviously. There is something called ejection fraction, it will be affected. Then examples in every video, I'll make these small 4 or 5 points. You have to write it down in some pages so that before going to exam, 2 to 3 hours before, you can just revise this topic in 4 to 5 points. So macrocytosis with hypersegmented neutrophils is characteristic because we saw this in peripheral blood smear, right? Then neurological features occurs only in vitamin B12 because vitamin folic acid has some other features. You learned it about clinical features. Then bone marrow is hypercellular. 3 times I said bone marrow is hypercellular. Then folate corrects anemia but not neurological damage. Hence, don't be fooled like giving only folic acid. Give always vitamin B12 with folic acid. Yeah, it was a bit lengthy video I feel, but I tried to explain it in a proper way. Just don't cut anything because this is the bare minimum you have to study in a megaloblastic anemia. If you try to clump up topics, like there are so much theory notes and all.